right, ladies and gentlemen, good afternoon. Thank you for your attendance at this session. We can all agree if Mark Luker, when he arrives, we're going to ask him a trick question. Okay, we'll be ready to do that. Thank you very much for coming. The speakers in this panel are, I'm Deborah Hurley. The speakers in the panel today are Peter Bootsma from the Royal Netherlands Embassy, and they're actually sitting in the order I'm going to introduce them. So immediately to my right is Mr. Bootsma, followed by Deborah Golden, who's from Deloitte, David Jacobs from the Electronic Privacy Information Center, Mark Luker not here yet, as you know, but will be arriving, we hope. And then on the end of the table is Latanya Sweeney from the Harvard University and its Data Privacy Lab. The subject of this panel is big data. And big data in the context, big data in itself is an interesting subject, but we are looking at it today, not all big data, but big data in the context of privacy and protection of health information. So that's our focus here. Medical information, medical data has long been of high interest to governments. It's well over 35 years that a number of governments have legislated with regard to protection of personal data and privacy, and with particular attention to medical and health information. That's been a topic of particular interest and concern, and there are many studies and a lot of work to protect personal information that has been done, particularly in Europe, back in the 1970s and 1980s. There are many examples of this in Denmark. There's a longitudinal schizophrenia study that's gone on for decades, and the Danish government in the latter part of the last century, in the 70s and 80s, spent particular attention to the privacy considerations as that data began to be computerized. Similarly, there was an early cross-border Belgian-French cancer study, and again, with the growth of electronic records, there was a lot of attention paid to how to protect the privacy of those individuals as that information was manipulated and used. So this is a subject that has had a great deal of attention given to it. So why are we talking about it again today, if the people have been talking about it for 35 years? It represents a couple of very interesting things. Medical data is usually a massive load of highly sensitive information. So if you can get that right and figure out how to protect that well, then you've solved a lot of other problems also. Medical information and health information, which I'm sure this point has been made already today, is some of our most intimate information. And then now, since we can trivially collect and manipulate DNA, it not only implicates that individual, the information not only implicates them and their privacy, but also, of course, reveals information about other individuals often without their awareness of that happening. So we are going to talk about big data today, but you'll see that the title of this session is Big Data, Big Problems, Big Solutions. So we all know there's big data, we all know there are problems connected with it, and you'll be hearing a little more about them in a minute, but it's time already, well time to begin talking about solutions. So I've asked the panelists to address that. I'm going to turn it over now to the first panelist, who is Peter Bootsma. But before I do that, I'm going to offer a solution. How about the solution that the default, as of today, is that personal information, including health information, is owned and controlled by the individual? How about that for a solution to big data? Okay, our first speaker Mr. Bootsma.
Thank you, Deborah. My name is Peter Bootsma. I'm the Counselor for Health, Welfare and Sports, so my portfolio is a little bit broader than health privacy. I have to thank Deborah Peel for... Oh, close. Okay, yeah.
Sorry, people are watching.
Okay. My name is Peter Bootsma. I'm the Counselor for Health, Welfare and Sports, so my portfolio is a little bit broader than e-health, but I have to thank Deborah Peel, who I met 3 years ago, and like many of us, I was touched by her enthusiasm and her drive to get health privacy on the agenda, so now it is also part of my agenda. Thank you very much. I was planning to say a little bit about the, let's say, differences between European and USA, but there's already been said a lot about it. I just wanted a panel, and Peter Husting mentioned also already a bit about it. But Still, I want to mention the main outlines as I'm scheduled here to be representing the EU. It's already said a couple of times, data privacy in the Netherlands, or in the European Union, is a fundamental right. And here in the USA, I don't need to tell you how things are organized here, but it's like a case in protection from the government. It's the Fourth Amendment on the prohibition of unreasonable search and seizure. It's about the First Amendment, the right to free speech and assembly. And what I also notice is that in a lot of things it is mentioned as a consumer issue, while in Europe it is a fundamental right. The Data Protection Directive has been mentioned quite often from 1995, and Peter Hustings already mentioned that the restrictions will be more and more tightened in the coming year or years with changing the directive in a regulation which will standardize all the data protections regulations in 27 countries of the European Union. In the US, it's more a mosaic of laws on financial data, health data, children's online info, and what I found a bit curious, there appears to be a separate law on video rentals. So I'm not sure what that is, but it was a bit... Then on the regulatory power, we have these National Data Protection Agency in Europe, and they are reasonably powerful in the sense that they can require organizations to delete data or to have organizations to pay fines. And also here in the US it is a bit more of a mosaic of all kind of violation of privacy rules. For example, if there is a monetary problem, self-regulations, the FTC, so it's a broad spectrum of regulations. That as an introduction, what I wanted to mention is something which has not been discussed very much yet today, is a completely different angle of data privacy, which we had a couple of incidents in the Netherlands recently. There was a University of Amsterdam, they did a study on data which are stored in the cloud, and one of the conclusions was that the US government in theory would have access to the Dutch data via the Patriot Act, and that created a big uproar in the Netherlands and also created a problem for our Minister of Justice. The problem was more or less not resolved because let's say because of the differences between let's say the Netherlands. I was personally involved with my colleague from Justice and myself in because in Parliament there were questions on it, and at the same time there was another issue also about the similar thing with the Patriot Act, which was about a French company which had a US subsidiary, and this French company was charged with making the Dutch passport and would have access to biometric data. And because of it, with this US subsidiary, also was the conclusion that on basis of the Patriot Act, the US government would have access to this Dutch data. We have been in contact with, let's say, US authorities about it, and the conclusion was more or less that the law is the law, but that there is a protocol on basis of this law which says that if there's agreements between countries, and we have such an agreement with the US, the Netherlands, that they would let's say request data on basis of the Patriot Act on basis of this agreement. But it's not possible to exclude that they could request that US companies which have control of possession, or it's defined in this protocol, to have access to the Dutch data. During this period we found out that in Canada a similar issue has been arisen in, I think it was in Ontario, but I'm not sure. And that made that the Canadian Parliament prepared and accepted a separate law on the data that would preclude the Canadian data being accessible to on basis of the Patriot Act. A second, let's say, incident was a bit similar on basis of this thing, which was quite prominent in the newspapers. Somebody thought, how about our health data? Because in the Netherlands we have about 98-99% coverage of electronic health records, but the communication between these health records is still a thing which needs to be implemented. The company who's doing that is an American company. So there was a big discussion that the US government, on basis of the Patriot Act, would have access to the Dutch health data. Questions in Parliament, our Minister of Health in Parliament, and so on and so on. So in the end, what happened is that these questions were merged in and also transferred to our Deputy Minister of Justice to request the European Union to take this matter up with the US government, and this is, let's say, the situation where it is now. So as an example of a complete different angle for privacy of data and privacy of health data. That was the second thing I want to mention. The third thing is we have now this European directive, which we introduced in our law. We have some other laws on the confidentiality of medical data. We have a special law on the interaction between the physician and the patient, which has also provisions on confidentiality and who has access to the data, issues like necessity, issues like proportionality. I mean, does the secretary have access to all kind of data? So, in theory, you would think everything is arranged well. But since January 1, until January 1, we had an opt-out system for this health data. So if you would not consciously object to, let's say, physicians or a pharmacist having access to the data, then it was assumed that you had given your consent. The database, which contained these numbers of patients, was 8 million patients, which is half the population of the Netherlands. Again, there was an incident and some discussion in the Netherlands, and so the system was changed to an opt-in system. So since January 1, we have now an opt-in system in the Netherlands for health data. So the infrastructure which contained this 8 million records had to be removed, all the patients which had not consciously opted in. So we're now down to 400,000 data, or 400,000 patients. So we have to start all over again to get up to the millions of patients which we have in the Netherlands. I think we'll leave it to that.
Good. Thank you very much, Mr. Bootsma. Our next speaker is Deborah Golden.
Thank you. Deborah Golden. I've been at Deloitte for over 18 years, focused predominantly on health sciences in both the commercial and the government sector, focusing on kind of a plethora of both from an implementation and solution perspective, as well as the implications for privacy and laws and regulations that need to go into those types of infrastructures. With the latest was just referenced around things like IHR and access to electronic health records. So I'll start a little bit by taking a step back and really looking at big data. Big data could be represented in a number of different fashions, but at the end of the day, it's just what that says, lots of data. And so what do we really want to do with that? I think we would be encouraged to not only look at it as big data, looking at it in a reactive manner, but how can we actually leverage big data as open data? And sharing data so that it not only benefits the organization, which is today how it's mostly being looked at, but how does it actually help the individual who owns the data, to the comment that was made earlier about individuals actually having ownership of their data and determining how to leverage that data to mutually benefit themselves as well as the organization that's seeking to leverage that data. I think in order for organizations to truly see a benefit, obviously there's a benefit of analyzing data. There's a benefit of being able to come up with a means to look at data and create historical parameters and analysis with that. But in order to truly impact our organizations and in order to truly impact ourselves as individuals, it's really about opening that data up to others to be able to share based on parameters that I as an individual have chosen to allow. I think one of the things that we look at with big data is we don't necessarily have an opt-in, opt-out opportunity, and so organizations leverage our data perhaps in means that we don't want them to use, perhaps to find out information about us that may not be beneficial for us as an individual, but really looking at it and saying, well, what could I benefit from? An example of that would be particularly in the health sciences arena. Organizations like Kaiser leverage specific data about me as a customer to monitor and manage certain manufacturing of prescriptions. And so that actually helps me as an individual. So I might want to have certain individual characteristics shared with other organizations so that, as an example, if certain heart medication that I'm taking has caused me problems, knowing that it's caused problems for perhaps others that eventually leads to a medical recall of a prescription becomes incredibly important to me as an individual. That type of open data to me becomes much more pertinent than what an organization may be using about my data in terms of big data in the way that it's mostly being viewed as today. Obviously, with that type of open data, though, comes the need to have laws and regulations and increased policy and governance over the use of data, which occurs in varying levels. It also requires organizations to be willing to understand information sharing and whether and how that's dictated. So who determines what is being shared, how it's being shared, the technology that needs to share it, the security over that sharing of that data. The complexities continue to go on and on and on and on. But what we're seeing is that leading organizations, leading governments, leading federal entities that really want to enable individuals, and again, the mutual benefit for the individual, is to come up with this type of open data so that I as an individual carry this type of information with me. We've seen this be very helpful in what we're calling things like communities of care. We have a lot of federal agencies who are looking at how to better, as an example, the Department of Veterans Affairs, how to better their veterans. How do I help those coming home? How do I help those who need rehabilitation? How do I help those find jobs? How do I help those with their medical needs? And leveraging things like social CRM is a way to get insight and data back from individuals in today's everyday to get that information and be able to share it with others. It certainly steps forward in terms of creating that, again, a community of care so that, as an example, let's say a number of people happen to be either tweeting or sharing via Facebook that they've just come home and they're having a tough time. That information aggregated might be able to enable an organization to actually set up perhaps a get well group, something at a local hospital or a church, so that individuals can actually come to that without necessarily having to seek that information. So again, that's helping a population of people based on a need that they actually have and choose to want to share. So that's an example of how I think things are progressing beyond just big data and big data analytics in terms of actually trying to enable the individuals through things like open data and social CRM. So I'll leave it at that.
Great, thank you very much, Ms. Golden. Next is David Jacobs from Epic. David?
Great, well, thank you, Deborah. I'm a lawyer at the Electronic Privacy Information Center, so I'm going to focus on the law and some of the legal tools that exist now and that might exist in the future to address privacy and to deal with big data. It might be no surprise to you to know that there isn't a big data law. That there's no law that's geared specifically to big data. In the U.S., we tend to adopt a sector-specific approach to privacy law. So that means a law for video privacy, a law for health privacy, and so on. And big data sort of cuts across all of this and involves many different topics. There are some existing laws that might, when you talk about big data and what are the risks and what are the harms, there are existing laws that might have something to say about some of these uses. I know one thing when you're talking about medical information, a lot of people are concerned that this information is going to wind up in the hands of their employer, and it might result in them not being offered a job or in losing their job. And we do have the Fair Credit Reporting Act, and that would require that any employer that obtains medical information from a credit reporting agency, they would have to notify the employee and obtain their consent in order to use that information, and then they'd have to give them a chance to access their information and to correct it if there are errors and so on. Now, there are exceptions, and that's sort of one theme with the existing legal protections, is that there are inadequacies and there are exceptions. And in the Fair Credit Reporting Act context, if the employer does this in-house rather than going to a third party, the law doesn't apply. So that's sort of a big exception. We also earlier today talked about HIPAA and high tech, and the HIPAA rules have tried to place some limitations on the disclosure of protected health information for purposes like marketing that people might feel uncomfortable about. But again, there are exceptions. You can do basically anything you want with de-identified data. There's an exception for face-to-face marketing, and HIPAA only applies to certain entities, and a lot of companies aren't included. Google Health, for example, is not a covered entity. And as we just learned today, state public health agencies aren't covered, and we saw what happens when their information is released. So there are a fair number of gaps and generally poor legal coverage of a lot of these issues and a lot of the issues that big data raises. So, even though there are inadequacies and gaps, the privacy law shares a common set of principles and a common core, and these are called the Fair Information Practices. And these are a set of technology-neutral principles that govern the processing of personal data from collection through use and through disclosure. And these are found in the Fair Credit Reporting Act, in the Privacy Act. You can find them in the OECD guidelines, in the 1995 directive. And recently, the administration just released its Consumer Privacy Bill of Rights, and this is a recent example of a set of fair information practices. And the report lists 7 practices, and they are individual control, transparency, respect for context, security, access and accuracy, focused collection, and accountability. And so I think that when you're thinking about big data, you can look at the FIPS, at the Fair Information Practices, and you can note that several of them are going to become more important and need to be emphasized more than they are now. And those are the participatory aspects of the Fair Information Practices, things like transparency and access and accountability. We're sort of nowhere near where we should be as far as the ability for a consumer or an individual to access their information and their medical information, and to find out, where it goes and what is done with it, and to exercise some control over that. And you're sort of largely excluded from important processes regarding your information, and I think that that is one partial solution. I don't think it's a complete solution. I don't even think the law alone is going to address these issues. You're going to need technologies of privacy, and you're going to need other tools. But to the idea that you should be able to access more of your information than you currently do, I think that would help a lot with a lot of these problems. And you know, in places where that information is used to make certain decisions about you, you should be able to access, you know, to the greatest extent possible, the logic behind those decision-making processes. And you know, there are various ways of kind of checking the fairness or the process behind these decision-making algorithms. And you know, I think that's where we're going to have to look to in the future. And so I think I'll stop there, and we can move on and maybe pick it back up in questions.
Great. Thank you very much, Mr. Jacobs. I'm going to ask, is Mark Luker out in the audience? Okay. Gone. Next speaker then is Ms. Sweeney, please.
Yes, so I'm not a lawyer, so I'm not going to tell you about the law, but I am a computer scientist. So I'm going to talk a little bit very quickly about what does big data really mean and how does it fit in with clouds and some of the things that we heard about. When I think about big data, I actually get excited about privacy, and because I look at the models that we have, and they probably mean privacy will get better. And the reason I say that is a lot of our problems come from giving data away. Historically, you know, data sets have been small. I could get a copy of it. I could give it to someone. I could sell a copy of it to someone. Now they've got a copy. Now they can do with that copy what they will. In some ways, the data map is a good example of that. When you look at the map and you see data's going all these various places. But what happens? So recently, I wanted to get a copy of all of the tweets made around the world in real time. So I go to Twitter, true story. I go to Twitter, and they have an API, but the API doesn't let me capture all of the data. And, you know, a tweet, the amount of data is basically 140 characters. That means my name is Latanya Sweeney, which is 15 characters. So roughly, if you type my name 10 times, that's the maximum amount of information. It's more than actually the maximum size of characters I would be capturing. I'm like, okay, bring it on. Let's fill up my hard drives. And when I talked to Twitter and I looked at the volume of data that they're getting on an hourly basis, all kinds of problems come up in trying to get the full hose. One problem is I get it in, I can't even process it. I'll spend all of our energy just getting this thing in, special network systems and so forth. And so that's what big data means. It means that it's so big, I can't even give you a copy of it. Like Twitter can't give me a copy of the tweets from the beginning of time. If I started capturing it now and we build this infrastructure and I can capture it going forward, I can't give you a copy. I can give you a copy of a subset. I can give you a way to glimpse at it. So that's lesson one I take from Twitter, is that big data means it's so big, we're going to have to start changing the way we think about data sharing. The second thing I look at is I look at Google. Google is like open data, free data, privacy is in the way, don't worry about it, look at all the beautiful things you can get to open data, right to the minute it gets into their system. And then it's like, oh, we can't possibly give it out. Privacy, search engine stuff, we don't give out our data. We don't sell our data. But we will give you a tool that you can analyze our data. So you can't get my searches and so forth. Google will argue all the time about all the freeness of the things that they might find on the internet and so forth. But you can't get out of it an easy way to get the data that they capture. But they turn around and they give me these beautiful tools. I don't know how many of you ever use Google Trends or Google Correlate, but they're gorgeous. In real time, I can navigate through their data. I can have hypothesis formation on the fly about what I think is going on with the data. I get to visualize it. Sometimes you feel as though you're visually driving through the data as you're trying to get answers. That is so cool. As a researcher, it's very exciting. So I learned this from Google that really what the future is probably going to hold with big data are really exciting new tools about how to navigate data, how to access it, and how to get my questions solved through the tools I have rather than grabbing the data. Because if you think about it, a lot of times the answer that I actually need doesn't require the sensitive data. It's a lot of the analysis that I have to do that require them to give me the sensitive data. But at the end, I can compute my various statistics. I can compute all kinds of things. I can find correlations and so forth. So that's very cool. So then what is it then that might bother me? Well, it's the same things that bother me now. I don't know who has my data. I can't get a copy of my own data if I want it. And it's bigger, and it's even, in a way, it seems like it's more hidden, but frankly, it's hidden anyway. So it seems like I would be, if I could solve the question of who accessed my data, I should be able to ask the system, maybe even in an automated way, and I should get an answer, and I should get a copy of any data that's about me. And that gives us a sense of check and balances. There was some conversation earlier about the boundaries. So data knows no boundaries with the internet. In our data-rich society, it does. And as long as laws want to keep this notion of, physical boundaries, which is what our laws represent, and the data is flying all over the place, it's changing our notion of policy in two fundamental ways. The first one is because it doesn't seem to respect our natural boundaries, our government boundaries, it means our laws don't work anymore. So when the health data, when my doctor sends his voice data to be transcribed in India, HIPAA doesn't apply in India. So if he has a problem with the company over there, they're free to do with that data whatever they want. It's only because they believe they have some kind of financial relationship that keeps them from finding other uses. But if somebody else wanted the data and maybe was going to give them more money, maybe they'd have additional revenue streams. And so this is a problem with the cloud. And so big data is one thing, and then where that data might sit in geographical boundaries is a different issue. And that has to do more with the cloud. I know we just had a panel, so I won't get into that. But it is often merged with big data, because usually when we think about big data, we do think about it going over these boundaries, being in a bigger place. But it doesn't have to be. It could just be local. So, and the last thing I would say is that big data on American citizens' information, health data will combine with your phone data, will combine with your utility usage in your house, to what cables you're watching and so forth. Those kinds of large profiles eventually end up in the hands of multinational corporations. And the problem with multinational corporations is they couldn't respect the laws or policies of any organization, of any place, regardless. There's just we don't have the infrastructure that says, oh, I got this data through this data use agreement, I got this other data through this contract, I got this other data captured over in here in this country because people over in another country want to see it and access it. And there's no respecting those relationships. So that's my sort of laundry list of both the promises and the problems.
Great, thank you very much. All right, I had asked the panelists, as you can probably tell, to be brief, so as allow you to be part of the conversation. So we'd like to open up now for questions. We're going to follow the following rules. If you have a question, signal to me in some way, and I'll note you and then keep an eye on you. If you have something, and there's two mics right there, you can come to the mics. And if you have an urgent intervention on the matter being discussed that you must make, wave two arms, okay? I'll acknowledge you out of order. Don't abuse that privilege, but I want it to be available to people to use. All right, I'm going to take I'm going to ask the first question here of this group, and as you have questions again, please either come to the mics or signal to me that you'd like to ask a question. One of the things I'm wondering, listening to all of you, is what are the characteristics of big data, if any, that make it different or remarkable, needing different kind of privacy treatment? In other words, is there a differential treatment criterion here, or is it a matter of making sure that we apply the rules that exist or enact new rules to cover personal information? Who'd like to comment on that? Peter?
So off the top of my head, I would say that there should not be very different laws applicable, because it's at least in Europe or in the Netherlands, data are owned by the patient, and the patient has control, or should have, as legally who has access to the data and what is to be done with the data. Quite a separate issue will be the data on the DNA composition of humans, and I'm not a lawyer and not a scientist, but I assume that there are issues which need to be regulated in some way, because there is a definite health benefit if you would combine those data with health data, because then you could determine, for example, for ailments which are very infrequent, and to combine them with health data, and that would be of benefit. Of course, the data would need to be anonymized, but I'm not really familiar enough with this issue to say something about it.
Okay, others? David?
Sure. Well, so one difference with big data is it makes it easier to infer sensitive information or information that you didn't disclose, and that, I think, has an impact. So maybe an example, well, two examples. One is the Target case, where through purchasing patterns, Target was able to predict with a high degree of accuracy whether or not someone was pregnant. They never collected the pregnancy, information. But they got it anyway because of the connections between pregnancy and certain purchasing habits. And researchers have done similar studies with Facebook likes, predicting sensitive information from what you like. You might never knowingly reveal this information. This is like sexual orientation, age, so on. You might never reveal this information directly, but you might like a bunch of different things, and through that information you can tell what you never revealed in the first place. And that, I think, might have an impact for a legal system that depends on the concept of personally identifiable information or sensitive information, and tries to kind of segment this information out and treat it differently. Big data sort of changes that.
Great, thank you very much. You're first, please.
I haven't asked a question today, so
Go right ahead.
So Professor Sweeney was talking about the big data and gathering information. It reminds me of Andrew Nigg and his search for concepts that are known in YouTube. And you really didn't have to look for a particular concept. It just through machine learning, they said, find me the concepts. And he found a representation of a cat. But he has a visual representation of a cat, right? But it wasn't anybody's cat. It was a made-up cat. It was a virtual cat. So is that anonymized data? And do you think that's a solution to access? I mean, on the other hand, David was just talking about going through individual records and associating them, but maybe through machine learning, is that a way of anonymizing data and getting clinically relevant information? What do you think?
Well, I mean, so let me just kind of backtrack and then come into your question. Historically, the three pillars of privacy have been, consent and de-identification has been one of them. And the general philosophy that led us to de-identification was the idea that your data could be freed. If nobody knew who you were, then why not give that data away freely and openly? And so that's the promise of de-identification. But I actually believe that in this world of big data, that kind of question is kind of going to change, because people aren't going to be giving the data away in big ways. They'll give small pieces out, and the smaller pieces are a little bit easier in some ways, or certainly one could argue are a little bit less than giving out every hospitalization in the state of Washington that we talked about earlier. But maybe I'll give a smaller set, or more likely probably giving increasingly less sets. So I think that it definitely gives us an advantage in the space of anonymization or trying to find de-identification.
Thank you.
You want to comment on that, Deborah?
Sure. I also think to try and eradicate an identity in today's world is becoming increasingly difficult. So as much as we might want to hide who an identity is based on giving smaller sets or only providing certain attributes, it's becoming increasingly almost impossible given the ability for me, again, as an individual to put information that I choose to put out there. So to take the information I choose to put out there and the information an organization may be collecting, it's also increasingly easy for them to figure out who I am, even though I might not have given them that data. So I would further, supplement that with, I think, someone looking at the privacy laws and regulations in conjunction with what organizations have to do to provide that level of transparency so that we can maybe consenting to something, but it's consenting to how that data is actually being used. I don't know that a lot of organizations have, well, actually there are probably a number today that continue to go out and actually articulate that vision to their stakeholders. So again, that I truly understand that signing something that says, yeah, I agree to letting you have my data versus how you're going to use my data might be two separate things for them.
Great, thank you very much. You're next, please.
People often refer to the potential benefits of big data. And as a practicing physician, one of the real challenges is the quality of the data. I often talk about the fact that big data right now, we're really talking about marketing quality data, not clinical research or clinical work, care quality data. In fact, we're so far from that in terms of standardization, et cetera.
Yep.
And we have to keep in mind that in order to do meaningful clinical research, you need a lot of information about an individual. You can't pick out 2 or 3 data points. You've got to have a lot of data points to make any meaningful analyses. And as we've learned today, the more data points you have, the easier it is to reconstruct identity. So data quality, I would love you to speak to that because frankly, it's terrible. It's great for marketing quality, and this is great for business, but as a clinician, as a researcher, it's worthless. Thank you.
Thank you very much. Comments, Latanya?
Yeah, I'd like to address it because I think, irregardless, I mean, we can argue whether HIEs eventually count as big data or not, but one thing is for sure, HIEs are going to get us into this interesting space that you were just talking about, where I have more data that's useful, might be useful in caring for the patient. The problem, though, is I don't know if it's really complete. And it gives the illusion that it's complete. But it might actually be missing a critical allergy, a critical other condition, or it might give me the false information. And so I'd actually found a couple of examples in the care of patients where, not in an HIE environment, but you could see that if it were in the HIE, where a case being omitted will lead the clinician to do the wrong thing, or if it was wrong and you don't ask the patient because you're not so reliant on your data. And that's a fear that I do have, and I do think that those cases are going to come up. They're going to end up in lawsuits because somebody's likely to be harmed.
Anyone else want to comment on that? Please, Peter.
Yeah, I agree completely with the previous speaker. Recently, I attended a meeting with the American Society for Clinical Oncology, and they have now a proof of concept where they combined 132,000 patients with breast cancer, and then on over 500 data points. And one of the big issues in there was the quality of data. So,
and also interestingly, I mean, if you think about traditionally in discussing medical privacy and medical data, the discussion, sort of the tension point has been around individual privacy versus the needs for epidemiological research, both of which benefit that individual. And so it's the individual, the rights and interests of the individual balanced against the collective that they're part of, I mean, their country or whatever that is, and the need, or the community at large, the need for epidemiological research. What's interesting, a lot of the discussion has shifted off that, as you're mentioning, because of a de-emphasis on quality and making sure to achieve quality measurements, to balancing between the individual and marketing opportunities. So it's then becomes the rights of the individual versus the right of particular commercial entities. So it's a very different equation at this moment. We have a okay, hold that thought, Adrian. We have a 2-armed person. Would you have to go to the mic, though? I'm sorry, because I think it's being webcast, so.
I just, excuse me. I wanted to go to her concern about once you go to a health information exchange, whether all that information is going to be on there. And I can tell you already no. We're moving working with our Health Information Exchange in Colorado as a pediatric institution, we are purposely keeping certain pieces of sensitive information from going into that system. So it's already happening, just to let you know. So in the bigger system, there may be missing pieces of information.
Right, Rich.
Oh, yes.
But what happens, but what happens if a patient shows up at another hospital in an emergency situation? How do you know that the piece that you kept off, what might not be the piece that saved their life?
That's the struggle. I mean, because we don't want reproductive information necessarily out there. We don't want HIV out there. We have kids who come in who are street kids, very, very scared, you know, and have certain information that they don't want passed out there because even getting them into the system is hard enough. And behavioral health issues we don't want out there. And there are drug interactions on the behavioral health side, especially where there are concerns, and we have it even within the hospital as to who can see these pieces of information. That's a struggle between like the emergency department and other parts where they say, we don't want this information going out because of this type of population we treat, and other parts of the hospital saying, but we need that in order to provide the full health care to them. So it is a struggle, and it's already happening out there. I don't know what the solution is right now.
Well, one idea is if you make it widely known that there are holes, that would be helpful. Because what creates that problem is when you have another clinician who believes that this is the record and that that's all there is, and no longer ask the patient, since the patient doesn't have to fill out a 5 million pages, the conversation may not even be there.
So on that level, it is understood that this particular health information exchange, that the information may not be complete.
And we've seen similar things across entities outside of hospitals into things like the jail systems for adults. So a lot of times if someone's been incarcerated, they might not be telling the truth as to who they are, what they are. And for people that have HIEs set up and their medical record, if they're not giving the right information, the hospital is not giving the right information, or their medical practitioner, the jail actually might not know that they need to be treated by certain medication. And there actually has seen deaths occur to that by not actually having complete medical records, where they actually are relying on this information due to the fact that they might not be getting the whole story from prisoners in this particular instance, which has actually been a result of some lawsuits. So who's liable? Is the healthcare practitioner that didn't provide that information? Is it the jail system that didn't ask all the questions, or is it the individual who perhaps didn't provide that information upon being booked? So I think we are seeing that in not just the hospital scenario, but beyond that for people who are leveraging the information.
Peter.
Yeah, a brief question I would have is that an individual decision by the physician what information he would enter into the record, or is that a hospital-wide policy because one physician finds this very sensitive and another finds other things sensitive, so it would be a mosaic of data which are not in these records?
So it's centered around our clinics. So it's kind of a clinic-centered decision. So we have our adolescent clinic and behavioral health as a whole. So it's kind of the decisions made around the particular department or clinic.
Good. Thank you very much. Okay. Adrian, you're next. You've been the soul of patients. Please go ahead.
The health economist Uwe Reinhardt, I think I'm butchering his name, yesterday at Datapalooza, and this morning Doc Searles here said the same exact thing, which is that data that's in use, that's in motion, is worth more than the data that is sold or at rest. And so I want to raise this issue of relative to big data in the sense that how do people benefit, economically benefit from the big data thing? In other words, does all of, we all know that there's going to benefit for society, public health, research, whatever. What part of big data can flow direct economic value to the users?
I mean, so one concept there is actually doing I would say, preventative health, so that we're actually, with today's healthcare costs increasing, right? So if I can actually be more astute upfront about using social media or data or analytics to help the constituency to actually be preventative in my healthcare. So I may have the potential, based on analysis, of having heart disease at 50. What other things is that organization doing to help me so that I'm actually reducing my cost in the future associated with medical costs? So there's a lot of the medical industries that we're seeing, hospitals as well, is, again, how do I create, I called them communities of care before, but using that data to actually prevent things from occurring in the future, so that I'm actually now looking at that as, I'm a doctor who's here to help you be healthier, a hospital here that I understand that you might have to be in the hospital, but how can I use that data so that I'm actually really being proactive about the help that I'm giving you? They've done studies to see how much actually economically that would help not only me as an individual with my health insurance costs, but also it would help people like pharmaceuticals to be able to better enable their drugs, to better enable their help of me as an individual as well.
Please.
I'm kind of dovetailing on that question and the question on the physician beforehand. I remember reading Harvard Business Review calling the data scientist the sexiest job of the 21st century. And as a physician, I view that role of epidemiology and public health really important, but frankly, a lot of this is not rocket science. This is a matter of saying who has the means and who doesn't. And as I start to see all the money poured into all this technology and analytics, the predictive analytics in particular, and the question of what kind of quality data that you're getting, I'm wondering to what degree, whether it's through how we construct peer-reviewed ways of using this data, and then really echoing it through policy that aligns consumers and takes these rights and moves them forward so that we have a much more just society. And I'm wondering how you can comment on that.
I mean, I think I said a little bit ago, and then I'll let my peers comment as well. I mean, I'm all about individual rights. I mean, so I think we have to get to that. I think organizations have to get to that. I think there has to be some level of transparency. From the technology side, unfortunately, if a lot of these organizations don't put money into the technology, there is, in many instances, limited amount of security and privacy parameters currently in place. So if those systems are going to be used to actually share data, it's upon the organizations to actually look and see if they can actually sustain that data in a secure fashion. When companies are using social security number as unique identifiers and it's being repudiated across organizations, probably want to make sure that at rest that data is safe, in motion that data is safe. And so there has to be actually, I think, an overhaul of looking at the data and where it's being housed and processed to make sure that those systems that are currently in place can actually secure them so that when I, as an individual, say, I'm happy to have it shared, I know it's being done safely.
Others? Anyone else want to comment on that question? No. Okay. Please, Peter.
Yeah, a very brief comment. Then I have to get back again to the issue of the quality of the data. Data is being discussed quite often in the sense of absolute thing. I mean, data. But we all have to realize that data are generated by a physician sitting at his desk, examining a patient, making a judgment, and then on basis of the judgment entering these data. So if you have good physicians, bad physicians, you have accurate physicians, and I mean, there's, to my knowledge, not very much research done, but maybe others know about it, is how accurate the information is which physicians have entered into their electronic health record, so that you actually check with the patient and with the other things to really see, is this the correct reflection of what actually is wrong with the patient.
Good, thank you. Now we have a good size but orderly queue on the right, but there was a lady on the left who had a question. Do you still have a question? You were in line before to ask a question? No? Okay. Please.
So I guess my question goes to the area of consent to share or not share your data, consent to do what you want with it. And it really comes down to the issue of how do you make that consent informed? How do we go about explaining So we sort of know that we can't absolutely 100% guarantee that if you share, that you'll never get re-identified, and we know something that the more you share, the greater the potential value, but the greater the risk of re-identification. On the other side, we do know some of the potential benefits. We have an IOM report that says there's $750 billion in waste, and learning from real data could attack some of it, but not all of it. And we have some other studies that have evidence that the learning can do a lot of good, but we also have clinicians, researchers say garbage in, garbage out, and the data quality is not there. How do we go about explaining this in a way that somebody can make all this different information on both sides? How do we go about explaining it in a way that someone can make an informed decision about whether or not they want to share and what the benefit to themselves and society would be if they shared and what the risks are?
Good. Great question. Please.
I'll jump in. Well, big data could change the formula a bit. So maybe the way it changes the formula is that if you did have a huge repository of data, and it was somewhat accurate and somewhat and financially useful, which are highly likely, then in fact, you could, that organization who's benefiting the most from that data could actually underwrite the harms for everybody else. I mean, it's sort of, I'm not an ethicist, so I can't speak to, if I gave you an insurance policy that said if anything bad happened to you, I would compensate you for that with your data. If anything bad with your data happened, that I would compensate you. If you lost your job, if you lost your ability to get life insurance, whatever that harm might be. Whether or not that ethicists would consider that the same as consent, probably not. But on a policy level, in terms of, then you get back to the original philosophy of de-identification. If you can't be harmed, it would change the formula, and it may force us to have a different conversation.
David?
And, this is sort of, this is related to consent, but it's also not explicitly about consent. Maybe you can sort of backstop problems with consent, because there are problems and there are limits to what you can explain and make it clear with, substantive protections. In certain circumstances, there are things that you perhaps shouldn't be able to consent to. And that might be one solution. Another possible solution is to increase the amount of independent auditing and access to these types of processes or studies, because a lot of consumers sort of look for cognitive shortcuts when they're trying to decide whether to consent to something or not. They'll go based on, what someone that they know is doing or what a trusted organization recommends. And so if you have, a robust set of actors that can kind of be consumer advocates and test a lot of this stuff, then that takes some of the burden off of consumers or off of patients to make these choices sort of in a vacuum.
Peter?
Yeah, I would think there would be a parallel with the policy of health insurance companies. And I understand since September last year, health insurance companies are obliged to provide a one-page paper in which they explain more or less in lay terms what is in the policy. So maybe that could be a solution, that you have these 35 pages reduced to one in plain language.
Please.
Scott Mace with Health Leaders Media. We're a magazine for healthcare executives. I was concerned about the tendency for payers and employers to be able, without getting consent, to go out and mine data in places like the FICO medication adherence score, or the new ways to correlate credit history with bad outcomes. I think there's people looking at linking credit history with hospital readmission rates, and I just wondered, what do you see happening in that area? Do you see a big surge in that kind of activity among payers and employers?
Good. Would like to take a stab at that question?
I'll definitely say yes.
Oh.
Definitely a surge across all kinds of things, the combinations of data that we can't possibly think of.
Yep.
And that's happening everywhere, all aspects of our life with all kinds of data.
In the United States, due to the, I mean, principally or largely, it's a U.S. phenomenon, especially due to, it happens everywhere, but.
No, it's around the world. I mean, if you look at a Global Pulse Initiative at the United Nations, I mean, in some ways they're using cell phones in other countries to learn about all kinds of social issues that they wouldn't normally know and for months later, but they can, by tracking the way the phone is used or by tracking the GPS information, they can figure out, oh, there's a riot or there's a this or that happening.
Good. Anyone else want to comment on that?
We've seen an increase as well in geospatial alignment. So, I mean, that's clearly something that, again, the more possibilities, it just keeps going up. So.
Okay, good. I'm going to ask this lady, then you, then that gentleman. Please.
You started off this discussion with the proposition that health information is owned by the individual, or should be. And there's been a lot of discussion about the individual giving consent, but to have it shared. But for the most part, that's not happening these days, as I understand it. So how realistic is it that we would come to that kind of a situation? And would it take a new law? Would it, or is this just pie in the sky, really?
Well, let me start by, I'm just going to jump in and ask Peter to talk to us a little bit more about the, since January 1, the opt-in system for health data. Because basically the Netherlands turned the pond over, if I understand, right? It was an opt-out system with 8 million people in the database, and then went to an opt-in system, which now has 400,000 people. So why the change? How did that change come around? What were the drivers or the incentives to change? And now having made the change, would you recommend it? And what's the experience? Could you tell us about that a little bit more for a few minutes?
That's a lot of questions. I think the change is because of political issues. The issue of connecting the health records has been a big political issue for about 10 or 15 years now in the Netherlands. And actually the law which would facilitate that would have been in place, I think last year, March, was it not, that in the Senate the party of our own Minister of Health had so much concerns about data privacy that they killed the law. So then the whole thing was back to square one. Then there was an initiative by the insurance companies, physicians organizations, pharmacist organizations, and then outside of the government they took the initiative to start this process all over again. But then immediately the whole discussion about privacy started again, and this organization, which is an independent foundation, they decided to come, let's say, to really be amenable to this discussion, and then to change the whole system from opt-out to opt-in, taking into consideration that there would be a lot of people out, and after January 1 it became clear that that was the case, because as you mentioned, we went from 8 million to 400,000, which in some way is a pity. The other thing is that in the Netherlands, the data are owned by the patient, and by law the patient can determine who has access to the data, with some exceptions. The exception is, for example, that insurance companies, they need some data because of billing purposes, so that's included in the law. And there are 5 organizations which get the anonymized version of these data for policy reasons and for reasons of supervision of, let's say, the insurance market and the healthcare market, and really to see whether policy, how they work out. So there are 5 organizations, but the physicians, they have to report out certain data. While they report out, they are already anonymized, and they are sent to a trusted third party. They encrypt and do all kind of things with that, and then they go to these 5 organizations. So 2 layers of, let's say, what that data are anonymized and that they're not traceable back to the individual patient, because these organizations only need the data for, let's say, as a group, and not the individual information.
Good. Quick
I would
comment?
say a sharp contrast with respect to data ownership is HIPAA doesn't acknowledge that you own your data. In fact, it goes out of its way not to answer the question of ownership. And instead, it just sort of says rights and responsibilities, that if you hold this data and you're a covered entity, this is what you can do, and this is your responsibility, and so forth. It doesn't actually say it's owned by the patient. And so when one of the things that's very confusing is we get these privacy notices you have to sign, and what you're signing is not your consent to share. It's just you're signing that you've received this notice, right? And it's irregardless, even if it did say it was asking for your consent, it would change zero data sharing practices of any of the covered entities because their decisions don't have to be based on it. And I don't know a single one that it would be.
Good. Next question, please.
I had two questions. Actually, the first was for Peter around the opt-in, opt-out changing. Did your organization have to develop any new practices or policies to provide assurance to the people whose data was being collected, who then chose not to opt in? How did you prove that the data was no longer there?
To be honest, I don't know. I mean, I have been informed that they deleted all the data of patients who had not actively opted in. The organization is now actively, let's say, providing information via website, via flyers, and so on, to assure what they are doing and what they are not doing. And actually, they have also opened a website in Dutch, which is literally translated iagree.com. And you can go to this website, find your physician or find your pharmacist, and then click some things that you actually allow this particular physician and this particular pharmacist and let's say the group around it, the specialists they're working in that area, that they can use your data and share their data.
Good, and you've been very patient, so I'll ask you a second question, but we're coming to the end of our time, so
as we work through
quickly.
these issues about being able to have consent or collect consent, has anyone been thinking about what happens to when people pass away? So as a child, do I have any ability to make decisions about whether or not my parents' health data will be shared or not shared after they pass away?
In the Netherlands, it doesn't change whether somebody passes away, because the patient who has passed away, he would have to give consent to and allow this access. So as soon as he passed away, nobody would have access anymore to this data, except in the exceptions I just mentioned before.
Anyone else want to comment on that question?
The only time we've seen that come up is also in the situation of beneficiaries. So sometimes the information is needed to determine cause of death, obviously, and then there might be lawsuits associated with that if someone's debating and needs actually health records to support a cause of death that would then lead to insurance beneficiaries. So we actually have seen that, but again, since the U.S. is certainly behind Europe in terms of some of this consent, that is actually ends up then being debated in a court who has ownership over that data.
Good. Thank you very much. Last question.
In the experience that I've had with healthcare use of big data, what I've learned is that largely there are at least three kinds of big data that are in current use: whole genome sequence data used for research, text data that's in the electronic health record systems and even in claim systems, and sensor data of the kind that if you were in an ICU, you would be generating sensor data, or mobile health data is another sort of sensor data. And in all the conversations around the value of those data, the quality of those kinds of data, they all seem to have qualified from a data quality perspective to be able to deliver value. You can tell a great deal about a whole genome sequence even though it's only 99 and 44/100% accurate. You can tell a great deal about sensor data even though the sensor might be miscalibrated. So I wanted to just ask you to interact a little bit about, are we at a place, so what I've seen is that we are at a place where data quality of big data sources are sufficient to add value, I wanted you to react to that, given that we've been talking about data quality a lot.
Okay, please, who'd like to comment on that?
Big data.
Yeah, I mean, I think, the truth is, I mean, it sort of goes back to Adrian's question about the economic opportunities. And so there's all kinds of opportunities in the health data that you described. There are economic opportunities. What we see economically driving data, health data, is primarily has been advertising. On that end has been advertising and predictive analysis, because predictive analysis is driven primarily by the insurance company, who basically says, I have two people who have the same condition. How come this one costs 80% more? And how do I predict which one's going to cost more and which one's going to cost less? And so they put a lot of revenues in that. The kind of data that you described fits into those camps as well, but it also serves other kind of performance issues within healthcare. And that's often its promise. In the research community, we care a lot about the kind of data that you described, for example, and for the improvement of healthcare.
Okay, Lila, because I get the last question, and here it is, and they each get 1 sentence to answer.
Okay, quick.
Okay, 1 question, and you each get a sentence or less to answer. What is the one thing, in your opinion, that can be done, that is actually doable, that can be done tomorrow, that would most improve health privacy in big data? Peter.
Go.
Come on.
I think, here for the United States, I would, if you would change to that people own their data.
Okay. Deborah.
I would say increase communication, collaboration, and transparency of organizations with individuals to the consent. What are we really consenting to, and what are we doing with it?
David.
I also might have to go with transparency.
Okay, Latanya.
Transparency in terms of reporting back who accessed data about me.
Good. Please join me in thanking this panel for their interventions this afternoon.